Okay, so we're going to continue with Chapter 41, Part 2, Structural Defects of the GI System. First, let's talk about cleft lip and cleft palate. It occurs at 6 weeks gestation. The cleft lip with or without the cleft palate is the fourth most common birth defect, more common among Native Americans and Asians than whites, and even less common in blacks, more common in families with a history of clefts and typically associated with some type of syndrome. It can occur by itself. Seems to be a connection with folic acid. In 1996, the U.S. started fortifying all bread cereals with folate to reduce neural tube defects. This was also reduced. So looking at figure A, it shows just a notch in the vermilion border. B is a unilateral cleft lip and palate, and C is a bilateral cleft lip and palate, and D is a cleft palate only. It can occur as a cleft lip, cleft palate, or both. Cleft lips can be a dimple in the vermilion border of the lip or a complete separation extending to the floor of the nose. Cleft hard palates form a continuous opening between the mouth and the nasal cavity, and the defect can include a cleft hard palate, soft palate, or both. So treatment and nursing care. Repair usually occurs at 3 to 6 months of age. They need special bottles with a longer nipple and either a larger hole at the end or you'll have to squeeze the bottle. They can't create enough pressure to suck from a bottle. Oddly enough, if the mom is able, babies can usually breastfeed with much easier because the breast can conform around the cleft. The big thing in nursing care with the children is post-op. You have to keep them distracted and unable to pick at their sutures to minimize scarring and infection. They cannot have pacifiers or suck their thumbs either. Post-op, they will eat a soft blended diet. They cannot have any hard cookies or toast or anything crunchy. Okay, let's talk about esophageal atresia and tracheoesophageal fistula. The foregut fails to lengthen and separate and fuse into two parallel tubes. This is obviously a surgical and clinical emergency. Esophageal atresia, the esophagus isn't open on both ends. It terminates as a blind pouch or connects to the trachea by a fistula. 90% do this. Surgery is often done in stages. Stage 1, they have to ligate the fistula and place a gastrostomy tube for feeds. Stage 2, the two ends of the esophagus are reconnected and it occurs during the 4th to 5th week of gestation. This condition is often associated with polyhydramnios. It occurs with congenital heart defects, GI and urinary tract defects, and or musculoskeletal defects too. Okay, now let's talk about the clinical manifestations and care. This is a significant defect and the many surgeries are difficult on parents. They need a lot of support and encouragement. Be truthful and honest and offer them as much information as you can. Common clinical manifestations include the 3 C's such as choking, coughing, and cyanosis. They may have excessive drooling, respiratory distress during and after feeds, aspiration pneumonia, apnea, and abdominal distension. So for pre-op, place an NG tube, start fluids, suction the airway PRN, and keep the head of the bed elevated. Post-op, monitor intake and output, monitor G-tube drainage, monitor vital signs, provide a pacifier, monitor for esophageal stricture, and provide emotional support. Let's talk about pyloric stenosis. It results in a complete obstruction of the sphincter. The lumen becomes inflamed and further narrows the opening, and the inability to move food from the stomach to the duodenum and ultimately vomiting and dehydration will occur. It occurs in boys more than girls, about a 4-to-1 ratio. Also increased incidence in the firstborn white male child. Tends to be a family history of the disorder. Hypergastrin is thought to play a role in the development of pyloric stenosis. There is a hypertrophic obstruction of the circular pyloric sphincter muscle. So what happens is the muscle that surrounds the pyloric sphincter grows too big, which creates hypertrophies, and basically obstructs the outlet of the stomach to the duodenum. The lumen becomes inflamed and edematous, which just makes it worse. Over time, as the baby eats, the vomiting becomes worse and more forceful until dehydration occurs. So let's talk about clinical manifestations and care. Onset of symptoms can vary, but it's usually in the first 2 to 8 weeks. Babies initially eat very well and then later start puking. Different formulas are tried and reflux is usually suspected. However, as the stenosis worsens, then projectile vomiting begins and the baby starts losing weight and becoming dehydrated. Diagnosed by abdominal ultrasound and upper GI. Surgery is typically done as soon as the baby is rehydrated and electrolytes are balanced again. You can do surgery such as an open or laparoscopically. They split the pylorus muscle to allow passage of food through. Babies tend to have a fast recovery and are usually drinking Pedialyte within a few hours after surgery. They go home within 24 hours on full feeds again. For nursing, NG tube pre-op, routine post-op care, assess bowel sounds, vitals, maintain fluid and electrolyte needs, minimize weight loss, prevent infection, and teach parents to monitor incisions and signs and symptoms of dehydration. Inguinal hernias. A hernia is the protrusion of an organ through the muscle wall of the cavity that normally contains it. Of the three types of hernias in children, the most common type is the inguinal. Inguinal hernias are often painless, in which there is an inguinal or scrotal swelling of varying sizes that occurs when abdominal contents extends into the inguinal canal. For babies, they like to wait until the child is at least 3 months old because of risk with anesthesia. As long as the hernias are reducible, meaning that they can easily be pushed back up, it is safe to wait. If it's not reducible, then the risk of trapped intestine and intestinal damage increases. Abdominal contents herniate downward into the inguinal canal or scrotal sac. Monitor for incarceration. I don't mean prison either. Signs and symptoms are acute, colicky type pain, abdominal distension, vomiting, edematous scrotum, fever, bloody stools. Surgery can be open or laparoscopic. Let's talk about diaphragmatic hernias. Abdominal contents protrude into the lung cavity through an opening in the diaphragm. It's caused from a failure in closure of the pleuroperitoneal musculature. Once infant is born, crying pulls abdominal organs into the thorax, resulting in respiratory distress, and you may see a barrel chest and sunken abdomen. It's a life-threatening problem. Remember that. Babies are admitted to the NICU where an NG tube is placed to decompress the stomach. Fluids and IVs are started and prepped for surgery. Babies are in PO and may require intubation and a ventilator for adequate oxygenation. It requires surgery to fix. Let's talk about the umbilical hernia. It's common in children, much more common in African American children. Results from weak or imperfectly closed umbilical ring. The omentum or small intestine protrude upwards when the baby cries or strains, and most spontaneously corrects by the year of age 1 by itself, or surgery can be done as well. Abdominal wall defects, such as an umbilical. So early in gestation, the guts are actually extra abdominal. They move back into the fetus by 11 weeks gestation. If they don't, you get an abdominal wall defect. Umbilicals occur when the intestines fail to return to the abdominal cavity by 10 weeks gestation, which is when the abdominal wall starts to close. These defects can be small or big, and babies can have their entire liver external. So the umbilical is an intra-abdominal contents that herniate through the umbilical cord. It's covered with peritoneal and amniotic membrane and is often associated with other anomalies but can occur by itself. Continuing with abdominal wall defects, we're going to talk about gastroschisis. That's when the abdominal organs herniate through the abdominal wall. It's not covered with peritoneal membrane. It's more common among mothers who smoke. These babies often have intestinal atresias too. Both umbilical and gastroschisis require surgical repair. These babies are NPO. They may have an NG tube. They're going to be fussy post-op. You're going to hold feeds until they have a stool. Then they have to learn to tolerate the feedings. Next, we're going to talk about intussusception. It's one portion in the intestine prolapses and then invaginates or telescopes into itself. It results in obstructed blood flow, ischemia, and necrosis. Hemorrhage or perforation if untreated. Again, occurs in boys more than girls. Typically occurs in children ages 3 months to 3 years. Seems to be preceded by a viral illness such as gastroenteritis. The telescoping intestine blocks the passage of stool, and when the walls of the intestine rub together, it causes inflammation, edema, and decreased blood flow, which leads to tissue necrosis and a loss of intestine. Both common sites is the ileocecal valve, where the ileum invaginates into the cecum and then further into the colon. Let's talk about clinical manifestations and treatments. Stools resemble red currant jelly because of the mix of blood and mucus. The classic triad of sudden acute abdominal pain, abdominal mass, and bloody stools is actually only present in less than 15% of children. You're more likely to see children present with screaming, drawing the knees to the chest, irritability, lethargy, vomiting, or diarrhea, constipation, fever, dehydration, and or shock. You can palpate a sausage-like mass in the upper right quadrant, and the lower right quadrant is empty. It's diagnosed by an X-ray or an abdominal ultrasound. It can be fixed with a barium or air enema in 80% of the cases. An NG tube is inserted for gastric decompression pre-op. Post-op care. Listen for bowel sounds. Watch for distension. Once bowel sounds have returned, then a liquid diet is resumed and then advanced is tolerated. Then we have malrotation or volvulus. Presenting symptoms are bilious, vomiting, bloody stools, abdominal distension, pain, or irritability. So what else can these symptoms be? It could also be for intussusception. So around 7 to 12 weeks, when the baby's guts are migrating back inside, they're supposed to rotate counterclockwise. If they don't, they're at risk of developing volvulus or twisted intestine, sometimes called malrotation, that results in bowel necrosis, short gut or bowel syndrome, and death. It's diagnosed by an upper GI. It's corrected by surgery, and this is another medical surgical emergency. Another disorder is the imperforate anus, the absence of an anal opening found during physical assessment of the newborn. Failure to pass meconium often occurs with anal stenosis and rectourethral fistula for boys and rectovestibular fistula for females. Presence of stool in urine is indicative of a fistula. Usually do an ultrasound to confirm and look for other anomalies. It's corrected with surgery and post-op dilations. So nursing care, NG tube, IV fluids, teach parents about ostomy care, and dilation procedure. No rectal temperatures. Patients with the future potty training is going to be required. Baby ends up with a temporary colostomy while they construct the anus and then dilate it to the appropriate size. Then the colostomy is taken down and plumbing is reconnected. This concludes part 2 of chapter 41.